Well, I will go ahead and get this started. This is Cynthia Snedden. I'm going to just give a couple of instructions, and that is to please keep your mute on during this presentation, and there will be time for questions at the end. Also, if you want to send anything in chat, we'll be monitoring that. At this point, I'm going to turn it over to Adam Stevens, who will do introduction for Dr. Corr. Thank you.
Thank you, Cynthia. Can you all hear me okay?
Yes.
All right. Well, good afternoon, everyone. Thank you for joining. I'm Adam. I'm a member of the Cancer Center Education Work Group. Just a couple of admin things to get out of the way, and then I'm excited to introduce Dr. Corr as our presenter today. So as Cynthia mentioned, just please remain muted during the talk, and then we'll have a Q&A session afterwards. And if you do have any questions during the talk, we encourage you to use the chat feature to pose any questions as we go, and then we can also get to those later on. Additionally, you'll find in the chat section a link to fill out a survey that's really useful for us, not only in terms of capturing attendance, but more importantly, identifying interesting topics. So today's topic, for instance, was suggested by you all, and so that's how we knew to reach out to Dr. Corr. So if you have a moment, just fill that out, and we can better serve what you're all interested in. So with that out of the way, excited to introduce Dr. Corr. Dr. Corr is a board-certified gynecologic oncologist. He received his medical degree from Vanderbilt University in Nashville, Tennessee, and then went on to complete his residency in obstetrics and gynecology at the University of Pennsylvania in Philadelphia. Following that, he completed his clinical training with a fellowship in Gyn-Onc at the University of Colorado, where he currently serves here as the director of clinical research for his division. Research-wise, his interests include developmental therapeutics and translational science in endometrial cancer with a focus on the Wnt pathway. He is an active clinical trialist with leadership involvement in national and local oncologic organizations such as the NRG, GOG, ETCTN. Dr. Corr is an avid cyclist, hiker, and skier, and is happily married with 2 children, Hannah, age 10, and Charlie, age 7. And we were talking earlier, I don't think any of that mentions that you're a surgeon as well in your spare time. So thank you for making the time to get through a lengthy introduction like that, and more importantly, teach us a little bit about some developmental therapeutics today. So without further delay, turn it over to you, Dr. Corr.
Thanks for that great introduction, Adam. I appreciate everyone's being here and the invitation to come talk to you today. I know Adam said that the topics were suggested by you, but I think I recall the topic was as loosely based as whatever you want to talk about. So I really love molecular analysis of endometrial cancers, and kind of wanted to gauge on and talk about how it really affects our treatment currently. So I'm going to share my screen here, and I do want to encourage the chat function. I'm not sure who's monitoring it, but please chime in, interrupt me. Normally I would love this to be in person and interactive. So I am not offended if whoever's monitoring just interrupts me with any questions. So can you see the correct screen, meaning just the slide, or do you see the presenter view?
Yes.
Okay. And I did it right for the first time. Right. See if I can make this fancy pointer too. You guys see the laser?
Yes.
All right.
The pointer, yep.
2 years and I'm into this. I know how to do it. All right. So as I mentioned, I'm going to talk about molecular analysis for endometrial cancers and specifically how it affects treatment. We are going to get to the weeds a bit of how we've developed this and why we do the things we do and kind of where we are and where we're going. And then at the end, talk a bit about how University of Colorado is kind of at the forefront of this. I do have several conflicts of interest, none of which are relevant today. I sit on multiple advisory boards and steering committees, mostly related to endometrial cancer, but none of them have any relevance today, and I won't be promoting any medications. So I'll talk about the background of kind of where we are now with endometrial cancer, and then talk about what we know of molecular markers currently, and then get into the details of kind of how are they actionable and what do we do with them. And as I mentioned, talk about where we are with at the University of Colorado. So, I think it's important in any talk that you get a good background of where we're at. And the reason why I put this picture up is, when you're talking about anything in detail or put all this planning into a project or a talk or something, you always got to pay attention to the background. Otherwise, it can all fall through. So the background of endometrial cancer is probably not going to be hidden to anybody on this call. And ultimately, endometrial cancer is actually on the rise nationally. Not only is the incidence going up, but the related deaths are going up. And the typical thought process behind this was, well, obesity is going up, and we all classically know that obesity is related to endometrial cancer. But interestingly, it's the non-hormonally affected cancers that are seeming to be on the rise and causing more deaths. So there's a lot of speculation to that, and a lot of research going into why that is. So this is a bit of the history of where we are with current treatment of endometrial cancer. As I mentioned, we used to think about this as kind of a low risk, high risk. We used to classically call this as type 1 versus type 2, and that loosely based on which ones are hormonally active and which ones are not. And the modality is a patient would get diagnosed, typically with postmenopausal bleeding. They'd undergo a surgery, and then based on the factors found at surgery from the uterus of the tumor, the size of it, the depth of it, how invasive it is, does it have something called lymphovascular space invasion? That would get them classified into a low risk, high intermediate risk, or high risk. And all that classifies into the risk of their recurrence risk. And so ultimately, do these patients require any adjuvant therapy? And the common therapies would be radiation or chemotherapy or a combination of the two. And so, all this is important, but there's got to be more to that. And so in 2013, which is a bit historical now, which is kind of funny to me, but the Cancer Genome Atlas evaluated endometrial cancer, and they were able to classify endometrial cancers into 4 main clusters. The interesting thing about that initial evaluation is that those 4 main clusters developed into they correlated with patient outcomes. And I'll go into this graph a little bit more detail down here. But these clusters, they evaluated the whole genome sequencing as well as RNA sequencing data about basically just a broad spectrum of endometrial cancers, and were able to classify into these 4 subclasses. And so let's talk a little bit about what the 4 subclasses are, because then that'll help us to talk about what the mutational status is and what the molecular analysis are to help us guide into where we've gone to with treatment for this. So the first one is called POL-E, and it's a catalytic subunit of DNA involved in DNA replication. And so there were initially 2 main hotspots found in this pathogenic mutation. Since then, we found 3 more hotspots, and there's been a lot more coming out with the larger databases specifically on POL-E. The second main cluster is called the MSI group, or hypermutated group, and MSI stands for microsatellite instability. These are basically a larger number of copy number alterations based on the mismatch repair genes. And those are MLH1, MSH2, PMS2, and MSH6. And there's an extreme correlation between the MMR genes and microsatellite instability. So microsatellites are attractive, repetitive, short segments of DNA that are repeated. And their relevance is that they have a higher mutation rates compared to other DNA. The next group is called the copy number low group. It's historically also be called the NSMP group, or the no somatic mutation present. I don't like that term, mainly because you'll see later on, I think there actually is mutational relevance there in this group, but this was kind of the catch-all group and where the majority of patients actually laid. It's copy number variations is kind of how they evaluated this group, and it was a lower aspect. This group typically was endometrioid type cancers, with a low mutational burden, and it does seem to have a more of a CTNNB1 mutational burden. And then there's a copy number high group. This is what we historically have thought of as just the serous endometrial types of cancers. And these are typically associated with the TP53 mutation. But as I'll get into more, there seems to be more to it than just this. So the TCGA was great. It was evaluated by whole genome sequencing and RNA-seq, as I said, to evaluate into these 4 categories. And but the reality is that it's not really realistic or reproducible to do that. Common even for us at a large academic institution to do whole genome sequencing on every endometrial cancer is just not realistic, but from a cost standpoint or a time standpoint. And so there's been a more expedited evaluation to get the same results, and that's called the PROMISE technique. And it uses a combination of pathological and immunohistochemical staining and Sanger analysis. And so this is kind of the general schema, is that you first rule out by IHC the MMR, and if they're deficient, then they go into that group. If they're intact, then you do the Sanger analysis to look for POLE. If that comes out, then you go on to do IHC of P53, and it classifies into the 2 different subclasses. So it's a lot easier and cheaper. And as you can see here, so here's a data output of the whole genome sequencing. If it's a heat map, which is hard to read, you need a biostatistician. It doesn't come out as an easy report. Versus IHC, which you just need a pathologist to be able to interpret for you and can get more information from it. So as you can imagine, it's a lot easier in this technique. So this past year, molecular analysis of endometrial cancer became a actual NCCN recommendation. We're ahead of the curve on this. This just came out this year, but we've been actually routine doing MMR gene testing by IHC since I think 2015 was the first time we started doing it on every single endometrial cancer, whether it's a new diagnosis or a recurrent diagnosis. And I'll go into later in the talk about what we're doing further from here on out. So it's not quite a guideline that you have to be doing it, mainly because there's still some interpretation of how we should be treating patients based on this. So let's get into the molecular markers. So we talked about these 4 subclasses, but initially this information didn't really help our treatment modality. All it did was describe these clusters, and we saw that they all responded differently. They all had different outcomes, but that didn't really dictate what we should do. Since then, we've kind of been able to dive down deeper into these 4 subclasses to find out what are the molecular markers and how are they actionable. So let's start off with some good news. So from a good news standpoint, POLE is great. So this is that first Kaplan-Meier graph that I was showing you from that first TCGA analysis. And as you can see, so this is a Kaplan-Meier graph which shows progression-free survival on the y-axis and just time on the x-axis. And all these little ticks are events, but this straight line up here basically means that everyone is surviving, or nobody is recurring, sorry, on this one. And this is blue as the POLE. So so this is obviously a hot topic of investigation, because why is this group responding so well to therapy or not even needing therapy? And this cohort has about 5 to 12% of endometrial cancers, depending on which cohort you're looking at. And as I said, they've basically got generally good outcomes. And so the trials moving forward have really been looking at de-escalating care for patients with this POLE mutation. So to kind of prove that, we've done some further analyses of patients for POLE evaluation. So GOG 210 was a great trial that was over 10 years. They just collected samples from all endometrial cancer patients from across the country, and they collected everything. They collected urine, blood, tumor, demographics, everything. And so a group out of WashU examined about 1,000 specimens from this sample and looked at it in comparison to the TCGA analysis subgroups, and really was able to show the same results, that in a real world situation, this POLE group, as demonstrated by the green lines here, had lower progression, or had better progression-free survivals, cancer-specific survivals, and overall survival. When we looked at other cohorts of treated versus not treated, we looked at specifically grade 3 endometrioid. So this is classically a higher risk population. And then there's the PORTEC-3 trial. This was a trial that looked at a higher risk population of endometrial cancer. And it looked at chemo plus radiation therapy versus radiation alone in high risk endometrial cancer patients. And so these are the patients that, we're not sure how much to treat or how little to treat. And it showed uniformly in all the groups of regardless of what therapy they got, that the poli group did well. And so initially there was a thought of, well, maybe it's just related to the treatment effect. And so, is it just because these patients got treated that they did well? And that turned out to not really be true. When they looked further at this analyses of people, yes, they all got therapy, but it didn't matter what therapy they got. Their survival and everything and recurrence-free survival were all equivalent and the same, leading to the hypothesis that it really doesn't matter what treatment they get, they're going to do well regardless. The second kind of group that we talked about was the mismatch repair or MSI high group. And this dates back to, and this is probably our most actionable group that we have currently. This refers to those mismatch repair genes that we talked about. And back in 2017, there was the first FDA approval for a therapeutic agent based on molecular analysis, and that was pembrolizumab for MMR deficient tumors. And it was broad spectrum. Any MMR tumor could get pembrolizumab approved. And so this really works by, this was one of the first checkpoint inhibitors, and many people here are familiar with this, but ultimately what it really is looking at is this PD-1, PD-L1 connection of checkpoints amongst the tumor and antigen presenting cells. And it blocks this connection and acts as a checkpoint inhibitor. And what this was one of the first articles to really show that mismatch repair deficient tumors were found to have a higher immunogenic environment and had higher response rates to immunotherapy. And so it's a bit more complicated than just this connection, which leads to why everyone doesn't respond, but there's a lot more research to be done. So in endometrial cancer specifically, since 2017, we've had 2 immunotherapies approved in endometrial cancer, specifically mismatch repair deficient, and that's pembrolizumab. So this went beyond just the MMR deficient group. It got its own labeling for mismatch repair deficient endometrial cancer. And dostarlimab most recently this year got approved with similar response rates. This is another PD-1, PD-L1 inhibitor. And the response rates of immunotherapy, even outside of the FDA ones, are pretty consistent, that between 40 and 60% will have an objective response rate to single agent immunotherapy checkpoint inhibition based on that molecular marker of mismatch repair deficiency. So within MMR, there's kind of been this thought of, well, is there really a better biomarker? So why are we not have such high responses, such as in melanoma or other tumor types that have much better responses than 40 to 60%? And so this dates back to, around the same time we were evaluating mismatch repair and pembrolizumab. We looked at is it PD-1 or PD-L1 expression correlating? Because that would make the most sense, right? If that's the way that it's interacting and blocking that connection, does the expression rate, is that the actual biomarker? And unfortunately, we didn't really find that to be the case. And so we found that expression of all these is really quite good in endometrial cancer, but it's quite anomalous, meaning that we've seen expression rates ranging anywhere from 1% all the way to 90%. And so it doesn't seem to really pan out to who was responding so much. And this got further evaluated by looking at PD-L1 expression and PD-1 expression amongst the 4 TCGA subclasses. And there really didn't seem to be a great marker in there for who was responding to immunotherapy and who wasn't. The last kind of analysis was reported out at ESMO in 2019. They looked to see, is there any correlation between MMR status, microsatellite instability status, PD-1 status, and PD-L1 expression. And you can see by this kind of Venn diagram, there's a lot of crossover, but there's quite a bit that doesn't. And so ultimately, we've kind of left, or we're at the point now that there's some correlation, but it's not a direct correlation, and we can't really use the other markers such as expression. What we know to be true is the mismatch repair deficient or MSI status, and that's the really biomarker that we're using currently. So what about the tumors that are not microsatellite instability or have mismatch repair proficient tumors? This is the next actionable target, is that there's a new combination that got approved of the combination of pembrolizumab with lenvatinib. And so lenvatinib is a multi-kinase inhibitor that targets VEGF. So basically, in simple terms, it affects the ability of tumors to create new blood vessels. And the initial evaluation had a little over 100 patients, and they saw amazing response rates. So in pembrolizumab alone, as a single agent in mismatch repair proficient tumors, we generally see a response rate around 10 to 15%, depending on which population. And here, the response rate was 38%. And so this was remarkably better than single agent pembrolizumab. And it got fast tracked, and eventually this year it got approved for mismatch repair deficient tumors. So this is another FDA approval in endometrial cancer. The results of this trial, which is called Keynote 775, were just impressive across the board. So let alone the 38% response rate, there was improvement in progression-free survival, improvement in overall survival, and disease-free duration. So it was pretty impressive. So let's move on to P53 mutation. So this is a mutation that we classically, I said, is in high-grade serous ovarian cancers and serous endometrial cancers. So we tend to think that there's a large correlation between the two. And here we evaluated two of those same populations that I talked about before, the PORTEC-3 trial, which was the chemoradiation versus radiation alone in high-risk endometrial patients, and GOG 210, which was kind of a broad evaluation of all endometrial cancer patients. And this kind of showed that the population for P53 was actually had a prevalence of anywhere between 10 and 25%. So it's not insignificant. And again, these are tumors that we typically just treated as based on the histology of a serous type and moving on to give them chemotherapy. So when we do the analysis of looking for P53 mutations, we see that this is uniformly the worst prognostic biomarker, and that in PORTEC-3 and GOG 210, they have the worst survival and recurrence-free survivals. And so this is obviously a group that we want to focus on, what's the ideal treatment for these, because, we can pretty much say that these patients need treatment. So this goes over again what that PORTEC-3 population was. And what I want to show about it, though, is the interesting factor about the chemotherapy aspect here. So this is a group where we were able to see chemo plus radiation versus radiation alone. And what we showed is that there is a clear survival advantage for people who got chemotherapy compared to just to radiation alone. And so this led to further evaluation of it. Well, is it the chemo that's the main driver? And what we are seeing is that it seems to be the case that chemo is the main driver for the P53 abnormality. And so those patients do better uniformly if you have a P53 mutation and get chemo. So this is most interesting when we look at kind of the P53 mutation, because as I said, we classically thought about this as just the serous histology. What we found is, when we looked at these other patient populations, is that we were actually missing a fair number of patients in that they had endometrioid histologies or other histologies, and they had a P53 mutation. And if they didn't get chemo, they definitively did worse. And this has led to kind of where we're moving in clinical trial now, and actually how I treat patients now. So any patient now who has a P53 abnormality, let alone the histology of the tumor, if they have a high intermediate risk patient population, they historically would have gotten just radiation in our practice. I will now offer them chemotherapy based on this information and this marker. Another thing I'll point out, and I'll talk a little bit later, is about people who have multiple classifications. So what if you have a P53 mutation and a POLE or a mismatch repair, or fit into another category? And there does seem to be a hierarchy on which kind of counts more. And so we'll look at that in a couple slides. Along the lines of P53, we tend to correlate and think a lot along the lines of ovarian cancer. And so in the past few years, we've had significant progress with PARP inhibitors in ovarian cancer related to BRC mutation and homologous recombination deficiency. And so there's a natural kind of evaluation to look at, well, do these P53 mutations have any HRD or homologous recombination deficiencies in them? And this is a great evaluation that kind of showed that yes, there is, and there is a subpopulation of this who may benefit from PARP therapy. And there are some ongoing trials, including here, that are looking at PARP therapy in endometrial cancers. So let's move outside of the TCGA classifications, and are there any other molecular markers out there? And there are, and this is probably one of the greatest successes of Dr. Fader and the group out of Johns Hopkins, is the HER2/neu expression. So human epidermal growth factor type 2. It's encoded by the ERBB2 gene, and in breast cancer, it's treated with Herceptin. And it was first been approved for HER2/neu overexpressing tumors in breast cancer. But what we found is that about 20 to 25% of serous endometrial cancers actually overexpress these as well. And so they looked at the use of Herceptin in this patient population with upfront chemotherapy and then as a maintenance therapy, and found improved progression-free survivals, and more recently updated with overall survival improvement. And so the use of this medication has already proven effective based on this marker. And they're now moving into earlier stage disease with overexpression of HER2/neu and evaluating to see if there's the same benefit with Herceptin or trastuzumab at this point. And I predict that there will be. L1-CAM is another biomarker that we know a lot about, but is one that we can't do much about at this point. So it's L1 neuronal cell adhesion molecule. It's a driver for tumor cell motility, and it's associated with a transition from the epithelial to mesenchymal cells. It's initially been reported and repetitively been shown to be a worse outcome for endometrial cancer and for survival. And these are more Kaplan-Meier curves that basically show that L1-CAM positivity, regardless of what stage or where you are, has a worse prognosis. And this is, as I said, been shown again in multiple evaluations. And the problem with this, and again, there's different authors just looking at it in different populations, and does it cross over? Is it associated with anything? The only thing we've been able to really show is that there seems to be an association with P53, and that 50% of L1-CAM tumors are P53 mutant, but and 80% of P53 tumors express L1-CAM. So this seems to be the closest correlation with L1-CAM, and so that P53, as we just kind of went over, we know a whole lot more about that in therapies. So it's kind of hard to gauge of how much we should include L1-CAM as something to evaluate. And this is kind of, I think, just more of the same that I was just mentioning. Is there anything else I want to say on this one? No. So this is my baby, right? We're not supposed to talk about having favorite children, but this is mine. This is what I practice. This is what we evaluate most in our lab. And it's CTNNB1. So it's an oncogene that is coded by, it's CTNN oncogene that codes for the beta-catenin protein. And it promotes cellular proliferation and carcinogenesis. And so mutations in CTNNB1 have been found to be associated with a number of different cancers, colorectal, breast, ovary, lung, and now most recently endometrial. So at baseline, beta-catenin is broken down or degraded by the destruction complex, which you can see here, in order to regulate or prevent cellular proliferation. But when you have a mutation in CTNNB1, it basically breaks this down. And so as this is turned on, you have a buildup of beta-catenin in the cytoplasm, which then relocates into the nucleus, and through a connection with the TCF-LEF, it increases transcriptional factors. And so the prevalence is something that we're looking at in all endometrial cancers. It's thought to be mostly in that low risk population, which we're finding is not so much the case. But the prevalence is kind of all over the place, in 19 to 50%, depending again on which group you're looking at. So, this group is very interesting because while we say that majority of these patients are treated with surgery alone, there is a percentage that do recur. And when they recur, it's a very poor prognosis and is often fatal. And so we're trying to figure out who is recurring and why. And I tend to believe that CTNNB1 is a large part of this population. We've shown that it's a higher risk in this patient population for recurrence. And the prevalence in this historical low risk is, upwards of 50%, which to me is pretty significant. And then Dr. Kerner was one of the first to kind of show that this mutational status does affect your recurrence-free survival. And so we here did a case control evaluation of these really low risk patient populations, stage 1 and grade 1, and looked at those who have actually recurred at any point in their career, and found that the only two correlations we found were CTNNB1 and microsatellite stability. And then importantly, we're the first to show that there's actually that they're not concordant, that microsatellite instability and CTNNB1 tend to be discrepant in their own unique risk factors. So are there any therapies for CTNNB1? So we're working on that in our lab and actually developing a trial shortly. But what they seem, which is interesting, is that this mutation tends to be receptive to any therapy. There's a couple therapies out there that have actually looked at CTNNB1, and one of the most famous ones is a combination of everolimus and letrozole. And there were only 4 patients that had the mutation in a trial that looked at this, but all 4 of them responded, and some of them even had a complete response, which is pretty impressive in this population. So to me, this is kind of another avenue to look at, is why are these patients responding to any therapy at this point, or what's specific about this therapy? Because we've also shown that they're responsive to medications like Avastin or bevacizumab. And so we're currently working with Wnt inhibitors in our lab to evaluate, will that addition really help from a therapy standpoint? So, many people know of endometrial cancer as estrogen progesterone dependent and hormonally responsive. And it's still true. We haven't forgotten about the good old therapies of progesterone and anti-estrogens. These are the currently listed approved therapies by the FDA on the compendium for anti-estrogens and progesterones for response rates in recurrent endometrial cancer. As you can see, the response rates aren't great, 20 to 25% and 10 to 20%. These historically were actually the best agents that we had up until that combination of pembrolizumab and Lenvima in the microsatellite stable population. But I still think there's a lot to be done with the hormonal agents that we have. When we go back to look at the progesterone response, receptor compared to the TCGA analysis, we find some interesting things. Is that that progesterone receptor commonly found have a good prognosis, and the red lines seen in the graphs here are the progesterone receptor positive tumors, while the green are the negative tumors. And so the prevalence is across all subclassifications here, but it seems to be most common in a copy number low group and with a good response. So there are combination therapies with hormonal therapies. It seems to be coming back in waves. Everolimus and letrozole is one of them we just mentioned about. Again, with good responses in certain patient populations. So I think there's more to learn about the hormonal therapies, and probably in combination factors with our new molecular classifications. There is more here. So I've lumped these 4 mutationals together as they're often closely associated. So ARID1A, PIK3, kinase, KRAS, PTEN. There's a strong correlation between these. ARID1A is an example of one that's typically found in clear cell cancers. PTEN is very commonly found in endometrial cancers, about 80% of them. And so there are targets along these pathways. There are things like mTOR inhibitors, which have shown moderate responses. But I think it's really the cross-reactivity of these that kind of have shown that there's more to learn about these inhibitors, and that there's probably why we haven't had historically great responses to them. So I've neatly pointed out that there's these subclasses of groups, right? For 4 subclassifications and then specific biomarkers. But in reality, as you can imagine, it doesn't always fit that you fit into one and that's it, that's your group. There's sometimes multiple classifications. And so this is kind of a newer topic that we're evaluating as we've kind of expanded our evaluation of molecular analysis is what about people with multiple mutations, and which one should we look at? And one of the first evaluations of this is done by Leon Castillo. And they found that in a very large patient population, there was about 3% multiple classifiers. So we're not talking large numbers. So fortunately, most people do actually fit into one category. But there seems to be a hierarchy here. And that hierarchy kind of lends to mismatch repair, POLE, and P53. And so what we tend to see is that that POLE tends to outweigh the others. And so that's good, right? Good responses from POLE. And so we like to see that. But I still think, we've got a whole lot more to learn about this, because as you can see, the percentages and numbers aren't really that impressive here that we can adequately say we know enough about multiple classifiers. So there are more mutations. We've got a lot more to learn. What I've kind of focused on is the ones that we have actionable targets on today. So, hopefully I begin to show you that this molecular classification scheme is no longer just information to have, but we actually make therapeutic decisions on those. So, we have the immunotherapies, we have the immunotherapy with lenvatinib, as we talked about. We have, a combination of everolimus and letrozole for CTNNB1 mutations. These are things that we actually make decisions about for treatment today. That's not advancing. But we're kind of in an era right now where clinical trial is helping actually define this. So here's a clinical trial run out of the European Union, PORTEC 4A, which is looking at specifically for mutational status. So things like with a POLE mutation, de-escalating care and actually giving them no adjuvant therapy, or delineating who gets what therapy, chemo or radiation, based on the P53 or the mismatch repair deficiency. Similarly, there's the Rainbow trial going on, looking at who to give radiation to and who not to give radiation to, and pulling out the POLE mutations again. And there's a number of other trials out there now that are really looking at treatment based on the molecular classification. So this is kind of what I showed you at the beginning of the talk of how we previously thought about endometrial cancer. And when you look at this group, this high intermediate risk group, I kind of only briefly talked about, it's kind of an elusive group. It's kind of, there's people in there who we know they're at higher risk for recurrence, so we should treat them, but we weren't sure exactly who deserves treatment or not. So that lends to the belief of we're certainly over-treating some people and we're under-treating others. And so that's kind of an area of interest. Well, I think this helps answer that. This is where I think we are currently today with molecular classification. And so I do think we are, at a point that that we do treat our cancers based on molecular analysis. But I think we're really in a transition point. And the reason why I say that is, over the past few years, and in a lot of different evaluations, there's been a mentality to mold the two risk stratification models. So the classically just looking at the uterine factors versus just looking at the molecular classification. And most are always trying to combine the two. But I think we're at a point that we really need to separate the two and really only start looking at the molecular classification. And hopefully these trials that I just mentioned will be able to delineate that and say we need to start looking at that and not predominantly use the uterine factors that we've used in the past. So, where are we at here at the university? And we're actually really ahead of a majority of the nation. I've talked about all these molecular testings, but kind of how do we actually do it? So as you can imagine, there's a handful of companies out there. There's Foundation Medicine, Myriad Genetics, Tempest Therapeutics, and that's just kind of the leaders of the field. There's many others out there. And then we have our own Colorado Molecular Correlates lab that also does evaluations here. So we developed, with the helps of Drs. Dara Eisner and Rebecca Walsky and Saki Kuntapalli, we developed our own molecular classification panel for all endometrial cancers. And starting last year, we started evaluating all our endometrial cancers for the mutations that I talked about today. So MMR was already being done, P53, ER/PR, HER2, POLE, CTNB1, PTEN are all now uniformly done on all endometrial patients. The ARID1 and L1 CAM, since those were less actionable, they're in the works and we're kind of validating them and they will be added, but they're not currently on the list. But for every endometrial, we get a report that tells us where the mutations are and what they have. So we do use this on our weekly tumor board and we make decisions based off of it. You know, there are barriers that people have come to us about, and you know, how can we do this? There's cost about and then the acceptance of utilizing the molecular analysis, and then the training on how to use it. You know, fortunately, we have the ability to do it here, and through our teaching, such as our tumor board, we do utilize this information. We're fortunate that we have the backing of the university to help us with the cost aspect, and we make sure that no patient gets any added cost to this because we do consider it standard care. Unfortunately, the insurance companies haven't totally bought in with us yet, but we are working on it, and hopefully these large national trials will help get cost not an issue anymore. So, you know, in conclusion, you know, molecular classification does have multiple identifiable targets beyond just that initial 4-group subclass that I mentioned. And it currently does provide beneficial targeted therapies. And so I do think it's absolutely standard of care for us to be getting these things. The patients benefit from this evaluation or collaborative work to get more molecular analysis. And so the question, are we there yet? Meaning, you know, are we totally at a precision-based model? And I think we're close. We're not quite there. We've got more to learn about causality and relationships, and we've got a lot more to learn about target therapeutics. But I think we're there, but not quite. And yeah, that's all of my talk. So I'm happy to answer any questions. Hopefully I didn't bore everyone, and I can answer anything.
Thank you, Dr. Corr. We've got the chat open. There aren't any questions in there right now, but we'll leave it open for a minute. Also, people can just unmute and talk to Dr. Corr directly.
Hey, Dr. Corr, I can start us off. Thank you for that talk. That was awesome. For the treatments for the CTNNB1 classification, you had a slide that showed it also targets endocrine, uses endocrine therapies. Is there, because there was, I think a following slide showed that there was overlap with the progesterone receptor positive treatments, everolimus and letrozole. Mm-hmm. Is there like any separation between the CTNNB1 patients, PR positive and negative, to see if they work together?
Yeah, great question. In the initial evaluations are published data to date, there's not really a known association. With my work with some Wnt inhibitors, we've done some preliminary assays and looking at this of whether the progesterone receptor has any relation to that, and specifically how do Wnt inhibitors work, and those who are mutated and those are not. And what we found is that it's seeming to be a lot more complex than just the progesterone receptor. And I think a lot of that has to do with the whole aspect of how estrogen and progesterone can act as both inhibitors and prohibitor and inducers of certain aspects. And I can say that it's not as simple right now. It's one of my future projects to be listed to look into, but I don't have a good answer for it now, and I don't think one is known out there.
Fair enough. Thank you.
We have people entering the chat saying, thank you, Dr. Corr.
Absolutely.
Were you surprised, Dr. Corr, when you found the HER2/neu being a good choice in those early, or there's some of them that you used HER2/neu on, right? So were you surprised by that?
I think it's less of a surprise. I guess for me, it kind of, a lot of the initial data that came out when I was a fellow. And so for me, it was just more education at that point rather than a surprise. I think the thing that I was surprised at is kind of the how many patients are actually express HER2 new. It doesn't seem to have a straight correlation that I've totally understood. From that transition from breast cancer into endometrial cancer, but the expression rates are, while they're listed at 25%, I'd say we have quite a high amount here who see that, and so it's always interesting to me to see who actually expresses that and who we can provide trastuzumab for.
That's one of the findings that you see on your initial analysis.
Yep.
That shows up there.
Yeah. So it's standard on our stage 3 and stage 4 patients right now. We're moving it up to our stage 1 and stage 2 there's a large clinical trial going on nationally to look at stage 1 and stage 2, but here at the university, we test everybody regardless of the stage.
That's really good to hear. Thank you. Anybody else have questions for Dr. Corr? Well, it doesn't look so right now, but we sure appreciate you being here and sharing all of this with us.
Absolutely happy to.
Here at the last minute, we have a question. How common, Savannah Gerard is asking, how common is BRAF and KRAS, or BRAF and KRAS in endometrial cancer at the university?
So the KRAS is not that one. We don't have a uniformity to. Well, sorry, that's not true. I don't have actual percentages for you. I can say that KRAS is more common in endometrial cancer. Because we've only been looking at this, over the realistically past probably 6 months, we haven't done any kind of initial analysis. We're kind of waiting for at least a year or so of data to see what our percentages and where we are. BRAF is not that common. We don't see too much of that. We don't initially test for it. Interestingly, I was actually just talking with one of my colleagues over at Kaiser, and they do test for BRAF on their endometrial, but we don't have a lot of that actionable at this point that we've seen successful. KRAS, obviously the combination with BRAF, I'm giving you a long-winded answer of we don't have a great idea, but I do know that KRAS is more predominant.
Thank you.
Yeah, it's just a question on what we do with it that I don't know right now.
Okay.
I have one other quick question, if there's time for it. Just as far as like what you do with all this molecular profiling data, either coming from Komoko or elsewhere, what's the process of digesting all of that? What groups does that go through? Who's actually involved?
Yeah, typically it's right now it's discussed at our tumor board weekly. When we go through our patients, it'll be discussed that this patient has a stage 2, stage 3, endometrioid cancer, and then molecular testing came back with this, and what do we want to do with it? That's currently where we're at right now with it, and so we are utilizing it for our therapies. Our long-standing goal is, we have probably one of the earlier prospective analyses of this, but I still think it's too young to do anything for it now. Right now, it comes straight from Komoko. They send it to the provider, and then we discuss it at tumor board. But that's really it, right? That's as far as it goes right now.
Cool. Thank you.
Okay. I think that we will call that the end then. And once again, thank you so much for being here.
Yeah, happy to talk. Thanks for coming.
Goodbye.